Evening, everyone. I'd like to welcome you all to this evening's Adults and Health Scrutiny Committee meeting. And as usual, we have a busy agenda. So to practical matters, please may I remind you all to mute unless you're addressing an item and raise your virtual hands should you wish to speak at any point in the meeting. I'll refer to Jane from governance if I need to record a vote or any procedural matters. So moving first to apologies. Do I have any apologies, Jane?
Apologies have been received from Councillor Jeff Dale.
Thank you, and Sarah Prima as well. So the minutes, this is to confirm the minutes of the Adults and Health Scrutiny Committee held on the 17th of June 2021. I'll propose them. Could I have a seconder, please? Thank you, Councillor Ainsley. Can I have a show of hands to say that we approve them? Thank you. Thank you. Can it be noted, we do have a few outstanding items on those minutes. If we could chase them, please, afterwards. There was, I think, Councillor Cross, you were actually going to forward us some details of a complaint from Oakham Medical regarding Oakham Medical Practice. Which I don't appear to have received. So if you could forward us that.
No, thank you, Madam Chairman. No, I made contact with both persons that had complained to me, and I asked them to make contact with Dr. Fox. Okay. However, having said that, and as Dr. Fox heard what I said, she should have initiated some form of investigation upon my word. Because, you know, when I say something, I do actually mean it. And if there is something wrong, it should be investigated. And by chance, I've been down there today to the medical practice and to the hospital, and both were running exceedingly well. Thank you very much indeed.
Excellent, excellent, Councillor Cross.
I have a point, but are we going to raise matters from the minutes later?
If you have a point to raise, then please raise them now.
Well, it was just for Alan, because he was going to confirm a recent presentation from the practice has gone into greater detail and address the issues discussed. Now, what happened on discussing the matters raised, please? That was I think minute 9, about the second or third para down.
Oh yes, that might follow on to the other outstanding items that we have, which were from Rachna Vyas. We had 3 things that I think are outstanding, which was the Oakham Medical Practice presentation that was going to.
You want to leave it then?
The comparable data for external services hasn't been received, and nor is the definition of hospital, as far as I could see. I don't know whether anyone else had heard anything or whether governance, I did try and check, but I had no record, so I don't know whether the governance team have anything. So could we mark them as a follow-up, please, as a matter of urgency? Thank you. Would that cover Councillor Cross, or would you like?
When we get there, I'm sure it will. I have every confidence in you.
Thank you. Thank you. So if we'll move those actions forward, and then if not, I'll chase those outside of the meeting. So we'll move on to declarations of interest. Do we have any interest to be declared this evening? I cannot see any hands up. Oh, sorry, Dr. Underwoods.
Yes, thank you, Chair. Item 8 on the agenda, the place-based care. I was heavily involved with the public engagement, the Health Watch Rutland public engagement, and the subsequent report, which has been partially used to formulate the paper that is being presented. Also, the Health Watch Rutland manager, Tracy Allen Jones, belonged to the group that formulated this paper.
Thank you. I've just noticed that Rachna has is on the attendee, so if we could let her through, please, that would be most helpful. Next, we move on to petitions, deputations and questions. Have we any deputations or questions, Jane?
Thank you, Chair. We have several questions this evening. The questions have been added to the website and circulated to committee members in advance of the meeting. Due to time constraints and the long and complex nature of the questions, it has been agreed to provide a written response to these questions in due course. We have Mr. Nebel, Mrs. Reynolds and Mrs. Fenelon here who would like to address the committee with their questions. So I shall invite them to speak to members one at a time. And as clerk, I must remind committee members of Procedure Rule 216, which states that no discussion shall be permitted with any reference to any question. So firstly, we have Mr. Andrew Nebel, and I will just promote him through into the group. Good evening, Mr. Nebel.
Good evening, everybody. My name is Andrew Nebel. I write as co-chair of Empingham Medical Practice PPG and also as chairman of Better Healthcare for Stamford. My particular concern is around the problems that emanate from the position of East Rutlanders, such as where I live in Ryle, and our concern that as the move to ICSs is still based upon governmental boundaries, we are still going to remain in a position where we are at the juncture of 4 different ICSs. And there is a serious risk that there will be anything but an integrated healthcare system for people living in this part of the land.
Oh, sorry, Mr. Nebel, I'm really sorry. I'll look to the governance to confirm this, but unfortunately, I'm afraid you have to read the questions as submitted. So I'm afraid I'll have to ask you to read them as they have been submitted to us.
Well, I'm happy to do that. I was understanding from the governance team, Jane, that there was a problem with time. And so I was attempting to summarize in the interest of the committee not being burdened with the need to me to read everything that you have before you in written format. But Councillor Harvey, if you wish me to read it, then I'd be delighted so to do.
Unfortunately, we are bounded by our constitution on this matter, Mr. Nebel, so I will have to ask you to read them as they have been submitted.
Thank you very much. And I just remind you my surname is pronounced Nebel.
Sorry.
It's difficult for you to master. I do apologise. Okay, well, the Rutland Health and Wellbeing Place-led Plan, which you are discussing today, accepts that for people living on the boundaries of other care systems, there may be extra complexity and unequal access. A major strategic requirement of all NHS England and inspection planning is the need to reduce inequalities between patients in access to and outcomes from healthcare services, and to ensure services are provided in an integrated way that might reduce health inequalities. The population of Ryle and neighbouring East Rutland villages are particularly concerned that our needs are disadvantaged and marginalised by our location at the boundary of different systems, and expect to see this system mitigated by greater attention to our circumstances in the place-led plan. I will not read the rest of my question because I proceed on the basis that time is limited, but I will read it if you wish, Councillor Harvey.
It is entirely up to you. As I said, unfortunately, we are bounded by the Constitution. That
well, could you assure me that my question will be considered in full if I don't read it?
Of course, of course.
Well,
that
that's
goes without
grateful.
saying.
I'm so grateful for that assurance. So there's my question. You've read the rest of it. I'm expecting a full response either today or in writing.
Thank you. And was question. I've got a question too as well. Would you like to? read
Question two is that the University Hospital Leicester draft business plan is predicated upon additional community facilities being provided and in place before its reconfiguration. So when will Rutland County Council publish the time-based plan for such enhanced community provision? And can the council confirm that it will be fully aligned with University Hospital Leicester's key construction milestones? There's a promise there that things will be in place before they're reconfiguring. And what we're seeing now is the reconfiguration is taking place before anything is in place.
Thank you, Mr. Nebel. We will ensure that a written answer is given to you on all those matters.
And might there not be any form of answer tonight? It is a major agenda item this evening.
It is, yes, but as I think governance had previously alerted that because of the complexity of all these questions, there will be a full written response given.
Well, complexity is accepted, but there has been foreknotice of these, and these are issues that are not new to councillors or in your consideration of these matters. So I had hoped there might have been a more active engagement.
Thank you, Mr. Nebel. As I said, a written response will be given. Next, we have Mrs. Cathy Reynolds.
Good evening. Sorry, I was lost for a few minutes. It seemed to drop me out.
Oh, that's okay. We can see you and we can hear you. Thank you, Mrs. Reynolds. Would you like to read your question, please?
Yes, thank you. Tonight's discussion paper on place-led plan for Rutland is to be welcomed, as is guidance on how the new integrated care system organisations will operate. The guidance on working with people in communities is very clear. For example, it tells us that working with people in communities is one of the essential enablers of success, and that challenges will only be tackled successfully by drawing on the diverse thinking of those who know the issues best, such as local people, those who are service users, and of course, unpaid carers. I'm concerned that as the integrated care systems are supposed to be operational by April 2022, time is very short, and there are several steps to get through to get a solid place-led plan for Rutland that has been widely engaged upon and developed in close association with those who have experience of services as advised in the guidance. So may I ask, what are the proposals and timelines for the following in the development of the place-led plan for Rutland? Plans for further engagement, including with local expert groups, for example, adult and children's mental health groups, those with long-term conditions, for example, diabetes or COPD, maybe given as examples, or travellers groups, for instance. This is needed to identify the local needs and any mismatch in provision, so to strengthen development of the local place-led plan. Can we have a date for when the draft place-led plan presentation is made to Scrutiny and to the Health and Wellbeing Board? A date for public consultation on the draft plan? A date for the report of findings on the consultation? a date for the final draft plan presentation to scrutiny. Not forgetting, of course, a date for the final draft plan presentation to the Health and Wellbeing Board and approval by the Health and Wellbeing Board. I'm presuming that all of those are already in the to-do list. Thank you.
Thank you very much, Mr. Reynolds. You are right, a lot of those are in the to-do lists. We'll bring in Mrs. Fenelon next, and then I'll address some of those questions afterwards. Good evening, Mrs. Fenelon. We'll just move you through now, and then we will.
Good evening, Mrs. Fenelon.
Good evening. I'm just trying to get my picture up. Doesn't seem to want to operate. Can you hear me?
We can
Yes,
hear
we
you
can,
perfectly
and we can
well.
see a picture of
I'm
you.
afraid until I can get this bit to operate, you'll have to make do with my photograph.
That's perfectly fine. You can ask your question. Thank you, Mrs. Fenelon.
Thank you. My name is Jennifer Fenelon. I'm the chair of the Rutland Health and Social Care Policy Consortium. My question is short. It says, a place-led plan must respond to the differing health needs of each community, and the Joint Strategic Needs Assessment, known as the JSNA, is a key building block which sets out those needs. But Rutland's JSNE has expired, and a new JSNE is needed urgently to help shape the Rutland Health Plan. When will the new JSNE be published for Rutland? Because it needs a lot of consideration. And can we have an assurance that the new place-led plan will include proposals to address the community's needs by drawing on the JSNA?
Thank you very much, Mrs. Fenelon. As chair, I'd like to thank you all for your questions and respond by saying that a full written response will be sent to you and will be published on our website within the minutes. Some of the answers to the questions you will probably hear this evening as well. In addition, I would like to reiterate that we continue to work in close collaboration with stakeholders such as the Health and Wellbeing Board and Rutland Health Watch to ensure that the voice of our residents is heard in such matters as community healthcare and integrated services. I will add as well that I think we received a further 3 questions. Am I right, Jane? That also
That's correct, Chair.
Quite complex and will also provide more details, which is why a full written response will come forward. It was felt that that would be the best way of addressing all of the questions, and they were all very well placed questions. So we shall move on to questions with notice from members. Jane, do we have any?
No questions with notice have been received, Chair.
Thank you. And do we have any notices of motion from members?
None received, Chair.
Thank you. And do we have any considerations of any matter referred to the committee for decision in relating to a call-in?
There have been no call-ins, Chair.
Thank you. And next, we will move to our substantive item, which is our place-led plan. Item 8 on the agenda is a joint presentation from the Council, the Clinical Commissioning Groups, Public Health and Rutland Health Watch regarding the draft proposals of the place-led plan. I'd like to welcome these colleagues to the meeting, but firstly, I'd like to bring in John Morley, our Strategic Director for Adults and Health, and he'll be followed by Councillor Walters for a brief introduction. Over to you, John.
Thank you very much, Chair, and welcome everybody. And I'd just like to just to take a minute just to thank everybody that's been working so hard over the months on this this piece of work, which I'll come to in just a second, because we need to acknowledge that all the panelists, my staff, health staff, PCN staff, third sector staff, volunteers, the people who have been engaged in this piece of work have also been the people who have been battling the pandemic and keeping our citizens safe, and continue to do so. And we're going back tomorrow to be doing that job in our rather bursting hospitals currently. I think it's important that we acknowledge that. And again, I'd like to thank them certainly on behalf of my services and my own staff. This is not the plan. You all know that, it's quite clear, but we do need just to underline that. This is a broad outline of the plan. This is what we intend. And we brought it here, it's suggestive content, because we want Scrutiny's input. That as we're developing the plan, we have your input. Is the focus right, for example? Is there anything that we've forgotten? And anything else that you can think of? Any suggestions? The actual draft plan itself, as was mentioned in the last Health and Wellbeing Board, will come to the Health and Wellbeing Board on the 5th of October, where it will be considered, and that will be the draft plan and all that sits underneath that plan. Otherwise, the detail to that plan. The plan is being put together by the IDG members. Now, that's the Integrated Delivery Group, which, because we're a small council, that's both our strategic and operational group, which is supported by 3 subgroups. So what's been feeding into this plan is the words of professionals, practitioners, analysts, clinicians, people from the CCG, PCN, the council, Health Watch, and the third sector. And there are other things that I could also cite, such as the Rutland conversation that also took a lot of interest in this particular area. And again, just to go back, just to finalise, just to put a little bit more context. Again, we mentioned this in the Health and Wellbeing Board back in June, that this plan will replace the Health and Wellbeing strategy. That's an obvious thing to do. The Health and Wellbeing Board strategy was out of date. Resources had to be put to the fight of the pandemic, and it rapidly became apparent that the needs of the population, the needs on our services have radically changed with the pandemic. And we will have therefore this single plan, which is post-pandemic. And that was also the case for the JSNA. With the new data we have, what we can see anecdotally coming through our front doors across the services, there's clearly been a big shift in need. And the JSNA is being revamped, renewed, refreshed alongside the plan, and is absolutely front and center in supplying the data for the plan. Alan, is there anything that you wanted to add?
Yeah, thanks, John. Could I first of all echo the thanks that you've given to our staff, health staff, volunteers, and everyone else who has worked extraordinarily hard for the last 18 months or so with extraordinary results. For them to have got this far at coming forward with a local plan is quite astonishing. I echo your comments about the JSNA as well. It wasn't deliberate that it's been left and is now a little bit late, but it is very fortunate that we're in a position to renew it after the pandemic rather than before. So it's by accident rather than by design, but I think it puts us in a better place than some authorities who accidentally, by not deliberately, devised their JSNA, and now they're going to have to do it again because everything has changed in the world. But to the members of the panel, it's not for me to tell you what to do, I never do, but to give you an indication, what I would love to hear is whether you want to be more involved in this plan. If so, how much more, and what mechanism you would like to use to become more involved, to assure yourselves that the voice of the residents of Rutland have been properly heard. I am convinced that they have, but that isn't good enough. You have to be convinced. So I'm interested to hear that. And I leave the rest to Sam to chair the meeting.
Thank you, Councillor Walters. John, would you like to come back in, or shall we introduce Emma Jane?
I suggest we get straight on to Emma Jane, Councillor Harvey.
Thank you. Emma Jane, if you would like to take the helm, you're more than welcome. Do you have a presentation to share with us?
I do. Jane, are you able to share that?
Bear with me.
You know, we'll all have just got the hang of these Zoom calls when
Yeah, I
we'll be
know.
back in public. And then we'll have to work out how to use PowerPoint on the big screen again. That'll take some time.
Let me share my screen. There we go. Can you all see that?
It's just coming up. It's black at the moment. There we go. Thank you so much. Thank you. So I will get on with this because the important part of today's meeting is the discussion that hopefully our presentation will lead on to, because as both Alan and John have said, it's really important that that discussion is held in order to inform us as to what we're doing, that we need to do more of, less of, and what your thoughts are. And this is why we've brought this presentation to you. This is an update paper. As John has said, it is a broad oversight for scrutiny members, so that you can make some suggestions for the detailed plan, which will eventually go to the Health and Wellbeing Board. So this is our update paper. So next slide, Jane, please. So if I give you a little bit of a context about why we are doing a place-led plan, obviously it is linking to a much wider system plan. We've talked about the integrated care system, which is across county, city and Rutland working together to actually put a system-wide plan in place through that integrated care system. To come down from the integrated care system, there is such things as place and neighbourhoods, and with Rutland being the size and the shape that it is, we are considered to be both a place and a neighbourhood within the LLR integrated care system. Now, as such, we need to have a place-led plan. And our place-led plan for Rutland is obviously going to be a very collaborative approach across health and care to basically improve the population's health and well-being. Rather than a focus on organisation or delivery, we want it to be very much a plan that actually brings to life what Rutland looks like, what the needs are, and how we are going to achieve the support for our population. Obviously, it is under the governance of the Health and Wellbeing Board. That is where our collaboration of health and care takes place. And therefore, the actual main plan will be presented to that board. What we are wanting to do as part of our place-led plan is obviously to strengthen our prevention, as we know that if we can prevent things from escalating, if we can prevent people from needing care, from escalating into crisis, then that is far, far better for both the population and our partners in care and social care to establish before we get to that crisis point. We also need to make sure that we're looking at our local and national priorities. There's lots of press at the moment with the social care side of things, but also we are very aware of the national priorities through the NHS long-term plan. And we need to address health inequalities, which we are very well aware of, and which we've had a lot of focus in the questions that we've heard already today. Jane, next slide. So Place is really important. As we know, Rutland is a place, and we want to make sure that our ambition in this plan is to offer our local population within our place to ensure that for a lot of the things that I've listed below, that everybody is able to access clear advice about staying well. How can they access the range of preventative services? What are those preventative services? How can we have a simple joined up care and treatment when people need it? How can we use digital services and obviously have non-digital alternatives at the same time, putting our population, our people at the heart of their very own care? How can we access proactive support to keep people as well as long as possible? So that's about people being able to do things for themselves and identifying what might they be. How can we identify where our vulnerable or our high risk population is, and what can we do to support them as well? How can we expect the NHS, through its employment, training, procurement and volunteering activities, and as a major estate owner within Rutland, to be part of a wider social and economic development and environmental sustainability of Rutland as well? Next one, Jane. So the purpose of this paper, Scrutiny members, is to share that collective collaboration partnership of the overview of the work to date. And it's not just me that you'll be hearing from, but I will be inviting my colleagues across public health and health to present further parts of this presentation to you, so that you can see that this is a collaborative approach that we are planning as a joint partnership. And we want to make sure that we have some emerging potential priorities presented to you so that you have input as to whether you feel that they feel right as priorities for Rutland. We want you to be able to sense check and give you an opportunity to look at what the work that we've done to date, to overview some of the data that we've used, some of the things that people have been telling us through Healthwatch priorities. What is it that we're saying to you, and does that actually make sense to you? What are the key areas where we feel there are significant gaps, where we need to have a look at some more focus on, and what are the next steps? This is just an overview. This doesn't give you all of the considerations, but hopefully gives you enough to have that discussion point. Next one. Jane, thank you. So just to update you on what we've done to date, as I have said, this has been collaborative. We have split ourselves into 3 working groups as we've come to the conclusions that we've come to present to you today. We focused on prevention, we focused on complex care, and we've looked at data. And those 3 groups have been having workshops, and they've come up with the preventative and complex and intelligent priorities that we're going to present to you. We've built on a good local strategic visioning work, and the thing that we have been pleased to see to date is that we've been able to look at Rutland. I know in the past a lot of the data and a lot of the visioning that we've been looking at has been based on LLR, or we've been linked in with counties specifically, but we have the data that has been brought down to a Rutland level, which has been fantastic. So it's not just about data, absolutely not. And we need to review the JSNA, and my colleagues in public health will be able to talk to you about that. And we need to look at the public health outcomes framework as part of that. What are the indicators of population health management data? What is this data telling us? But we need to make sure that we've got some wide sources of information. It's not just, as I like to refer to, bean counting, but we've actually got the patient and the people's voice in here as well, that we've had resident engagement, and that Healthwatch Rutland and the Future Rutland Conversation have been instrumental in actually looking at the way forward in our priorities. So what we really want to achieve, what our outcomes are, is that we want to come up with a vision that is actually meaningful to our residents and to our partners, that it has strategic actions that we can make sure that our partners are accountable for achieving, that it is a collaborative delivery, that those actions will be health, social care focused, and that we will make sure that the actions that are chosen will have the greatest impact for our population. And that obviously, if we're going to have some actions and we want to have some outcomes as a result of that, that we will make sure that they're monitored and that the delivery of the plan will have continuous engagement and checking back with our residents. That if we say we're going to do something, we will do it, make sure that it's made a difference, and make sure that our residents can see that that difference has been made and it changes people's lives as a result. So I'd like to now hand over to Viv, my colleague in public health, and she's going to talk through the next few slides for you.
Thanks, Emma Jane. Jane, do you mind just going on to the next slide, please? Thank you. So yeah, just building on what Emma Jane's talks about and just providing a little bit of reassurance around the JSNA. Although we haven't got a defined JSNA document to present to you today, what I do want to reassure everyone around the table is that a significant amount of analysis has been done in terms of reassessing what the needs of Rutland are. So it may not be in the format of a JSNA, but a significant amount of data and looking at quantitative data. So like Emma Jane was saying around the bean counting, but also that qualitative data and that engagement work, and what our community has been saying has also been very much the thought and the backbone of where these priorities have come. What I will say as well is these are draft priorities. We're at a stage where we're just forming what we think those priorities are, coming from the data that we have assessed. But we are really open to that feedback and really pleased to be here today to be able to get that from you. So I'll just take you through in terms of what we think the vision and the strategy has come from. And as Emma Jane has mentioned, this has come from, quite a long process of engagement that's happened over several months. A lot of my colleague Trish has done a lot of the work on this before I came onto the scene. So, thank you to her for this as well. So in terms of an overarching vision, what we're looking for is to have safe, healthy, happy and caring communities in which people can start and thrive their lives together and be that throughout their lives. And I suppose our overall goal is to have active communities that are living well. And the range of priorities I'll go through in a moment, we've got are the sort of key areas that we think that we can deliver to achieve those and prioritise the action through the Health and Wellbeing Board to drive some of the work on these areas. So we've got reducing health inequalities, best start in life, staying healthy and independent for as long as possible, ensuring equitable access to services for all residents across Rutland, and then preparing for population growth. And one of the things that I would say around this is we've put them as numbers in the presentation today. Each priority is of the same standing, and it is also acknowledged that the priorities will interlink into each other. So it's not that just because it's presented as the first priority today, that means it's the highest priority. It just means that's just the way that it's fallen in the presentation. And we can also look at the feedback in that in terms of if there are particular approaches that people are keen to see when we move on to developing this into the actual strategy that will go to the Health and Wellbeing Board in October. So next slide, please. Thank you. So the first area to consider is really building on some of the work that will have already been done around Rutland, but is also being much more prioritised through the NHS long-term plan and the ICS generally, and that is looking at how we reduce inequalities across Rutland. And I think the real area that I wanted to point out here is that when you look at the data, some of the things that are really key behind this is that when we look at healthy life expectancy in females, that's actually decreasing at a rate faster than the national average, which is quite an unusual pattern to what I would expect for Rutland. So we really want to sort of unpick that particular area and really understand what it is that is causing that to happen, because that is something that I think buckles the trend in terms of what we see in comparison to other indicators for Rutland. I think we also need to acknowledge that although Rutland overall is a very affluent county and generally does well on many indicators, there are real pockets of deprivation. And what we're really looking at in this priority is to use a proportionate universalism approach, which is about having a good level of universal provision for all, but then really looking at how we sort of level up the social gradient. So we know that everybody is on a gradient in terms of health outcomes, and it's not about bringing people down, it's about bringing everybody up to achieve the best they possibly can. And what there is a lot of evidence around that as well is that having more equal societies and things like that also really builds in terms of social cohesion and social capital, and that will link into some of the other priorities that we'll be looking at later on. So we've talked about where we think some of the focus areas will be in terms of female healthy life expectancy, but we've also seen through some of the data there are some particular groups that we know are at disadvantage or are not achieving the health outcomes we would like them to achieve in Rutland, and we've mentioned some of these on the slide here. So in looking at special educational needs children, the armed forces, prison population, carers, and some mental health issues in terms of farming communities. And that doesn't mean that they're the only ones that we will look at, but they are the ones that initially are popping up from the data. And when we look at what the engagement work has said in terms of that, we also know that there are particular health inequalities around people living on the boundaries, and as they do have more complex access to services, a range of services, and we'll come on to that in one of the later priorities in a second. So can we move on, please, Jane? Thank you. So the next priority we've got highlighted is around having a best start in life, and many of you will have heard about the really strong evidence base around that first 1001 critical days of life to really develop really strong foundations so that individuals can strive and really prosper as they go into sort of older adults and adulthood. And the data is very, very strong about those first 1000 critical days. So that is almost pre-conception up to when the child is 2 years. So that would definitely be a priority area that we would want to consider and build on. And I think that's another thing that I want to be really clear about. There's a lot of great work going on in Rutland already, and this is about building and strengthening on some of those work that we want to achieve moving forward. In terms of other particular areas that we'd like to concentrate on, so we've said about the under twos, but there are some indicators around school readiness and the under fives. Again, looking at special educational needs. There are a couple of indicators around school vaccination, and we know that vaccination generally for the more mainstream vaccinations has dropped off during the pandemic, and that's something we'd want to make sure we maintain and keep high rates at. Tooth decay and also obesity are other areas that we'd want to concentrate for our sort of children agenda. And again, linking into that engagement work, what did our residents say? So there's a lot of themes around minimising that travel, people feeling that there's it can be difficult to get to some services around children and young people, particularly some specialist services, and what can we do to support that? And again, we come on to some of those themes in a later priority. And then also around information and education, and really how we can support parents to support their children to have the best start in life, and particularly looking at that health and well-being impact. And we know there's a lot around emotional resilience and mental health issues that we know are particularly bubbling from the pandemic as well. So next slide, please. So priority 3 is quite a broad priority, and it is really about staying healthy and independent for as long as possible. So what we want to really do is make sure that we have a real strong prevention lens in everything that we do, and that we're really considering how we can have a preventative approach in all of our services, so that we can really sort of bring in interventions a little bit more downstream and really try and stop the progression of some people needing health and social care services later on. So we really want to embed an approach where we are supporting our local residents to self-care and remain independent, so that they can live the lives that they want to live, how they want to live for as long as possible. but also acknowledging that by doing that and having that preventative approach, it will also help us manage healthcare budgets and demand, because we know they will increase, particularly when we've got increasing populations and increasing and older populations coming in the future years. So the real key theme will be about that shift into a more preventative approach. And again, it's building on the work that we already are doing. And some particular areas that we want to concentrate are really having an empowered and self-sustaining local community, looking at frailty, and in particular areas around falls. Really concentrating on individuals that have a number of comorbidities. So we know that actually when you look at cost in health and social care services, a lot of that is driven by the number of comorbidities or the number of conditions that an individual has rather than age. So it's not that aging, it's obviously we appreciate that as people get older, the likelihood of those getting those comorbidities increases, but it's not age that actually creates the cost, it's the comorbidities that are around that individual. So what can we do to reduce the likelihood of that individual developing that second or third or fourth or fifth comorbidity? Other areas that the data is highlighted is around obesity, dementia, a couple of particular vaccinations, so shingles vaccination, flu vaccination, HPV vaccination for obviously your more in your children's, and then also looking at social isolation and also a strong focus around mental health. So in terms of what our residents said in this, again, it was talking around that there are facilities that maybe people don't know about. There may be areas that we feel that we could do better in terms of provision, particularly talking around sport and physical activity and social activities, and in particular those for maybe disabled young people or those with learning disabilities. And I think another discussion is around how we can deliver those. So can we do them in mobile or activity groups, or can we think about doing those in a different way? So next slide, please. Thank you. So priority 4 is around having an equitable access to services. And I think I've picked up on some of this in some of the previous slides, but we know that Rutland is a rural county and it borders lots of other local authorities and healthcare systems. And that provides lots of opportunities, but it also provides lots of challenges. And that can provide a number of challenges for people in terms of accessing services, navigating the system, or having long travel times. So what we want to do is to make sure that people can receive the care they need in the most accessible way, and that we are reducing some of these barriers for accessing services. So particular areas that we'll be looking at here is what services can be delivered specifically in Rutland. So particularly looking at UHL reconfiguration, how we're using the Rutland Memorial Hospital, and the development of some of the LLR community diagnostic hubs and what potential there is there. But also can we deliver services in a different way? And I think one of the advantages that we have actually had out of the pandemic is it's really pushed innovation, and it's pushed services to be delivered in a slightly different way, acknowledging there's been tremendous amount of loss and sacrifices that people have had to make through the pandemic. But where we have had innovation, it's about how we utilize that and we build on that. But acknowledging that that's not going to work for everybody. So making sure that if we are looking at digital solutions, that we're also considering how we have that equitable approach for people that may not work for, and we don't increase digital inclusion. And that was one of the themes that came out of the survey, as well as increasing access and reducing travel, and also making sure that we've got a particular straightforward more route around diagnostic and treatment. So next slide, please. So the final priority that we've got prepared for you today is around preparing for that population growth. So we know there's going to be significant population growth, so 14% increase in population growth by 2040. And what's really significant about that is that growth is much more heavily balanced in the older age group, so your over 65 age group. And we know that the over 65 age group are more likely to have stronger health and social care needs. And also many of those may not be contributing from an employment point of view in Rutland in the same way. So how are we going to manage that enlarging and all aging population? So we've got some figures there in terms of what those numbers will actually look like. And it's really about making sure that we think about how we integrate health and care services across Rutland to support that, how we make sure we've got the right infrastructure to support that population. And that might be in terms of particular health and care social services models. It might be around wider infrastructure, so thinking about some of the wider determinants of health and talking about obviously housing and planning and roads and transport. It might also be around how we're looking at the demands in our neighbouring local health systems and local authorities and what the impact is going to be there, but also embedding almost a health in all policies approach to health and equity, so that we're in everything that we do, we're considering what the health angle will be on that and how we can also reduce health inequalities. So in terms of what people said around that, so people were valuing the partnership between the individual and family and health services, and they want to be involved around how they can develop that, and acknowledging that, you know, there are some areas that are more defined and we know where that housing is, and there are some areas that we'll need to do a little bit more work on moving forward. So it is about working with that emerging housing need as it comes on. So that's over to me then. So I think, am I handing over, is it to Charlotte? Is it?
Thanks, Viv. So it's going over to Jo now, I think, from the CCG, please.
Thank you both. So linked to all of those possible priorities, we thought it was really important for us just to outline what the current services are across Rutland. So this slide here just sets that out. So that it's made up of 4 GP practices making up the PCN. Got some information there on elective spells and non-elective spells. We've obviously got the Rutland Memorial Hospital that provides a wide range of services, and I'll come on to a little bit more detail in that, and I think in the next slides. But then, of course, we've got the Rutland Better Care Fund programme, which is all around the prevention agenda. And there's a list there of all the services and the initiatives that are happening now across Rutland. Next slide, please. So this is a list of all the available services that are currently being provided out of RMH. And I don't propose to read the list out to you, but that is just to give you a flavour that there's a number of services that are available from RMH. Jane, next slide, please. And this slide here is about the inpatient community hospital, the beds, and that's basically made of a multidisciplinary team of consultants, advanced nurse practitioners, nurses, physiotherapists and occupational therapists. And the aim is to plan to a safe discharge back to a patient's home. And the percentage is changed from my slide, but you know, there is a good percentage that do return. I had 85% patients return back to their own home, so that's slightly different from the percentage on that slide. That's to a care home. Okay, so that, if you just look at the bottom left table, I think that's a really interesting table, because that shows you that the majority of Rutland PCN registered patients are accessing RMH, and then following that it's St Luke's and then Melton Mowbray. Next slide, please, Jane. And of course, from RMH, there is the Oakham Urgent Care Centre and also the Minor Injuries Unit. Again, you can see there that it's a good coverage from Rutland PCN registered patients. So over 70% of activity over the last 2 years was for Rutland patients. And then for Oakham, it's 67% of the overall activity. Next slide, please, Jane. And this next slide is around outpatient attendances for older people, new attendances and follow-ups. And I suppose the biggest thing really to pull out of that, as you can see, like the top 3 specialities that are being used clinics are the ophthalmology, dermatology and rheumatology. And absolutely, as Viv pointed out, we know that the greatest growth in the population is going to be in that 65 plus. So we know that there's going to be a greater demand for those services. And we absolutely need to look at what more clinics or diagnostics that we need to bring closer to home. Next slide, please, Jo.
That's back to me then, Jo. Thank you very much.
Thank you.
So just to sort of sum where we are with all of this, so that you can understand why we've come to you, I guess, really, is what we want to do is take all of the stuff that we've talked about in those slides and actually translate that into some sort of strategy that is meaningful, and have an action plan within that strategy that will be shared with the Health and Wellbeing Board on the 5th of October. So tonight's an opportunity for members of Scrutiny to really tell us, are these things that you can resonate with? Is there something else that you feel that we're missing? What would you like to see in that strategy that we have or haven't said in the priorities and the slides that we've shown to you this evening? This isn't a strategy that's going to be put on a shelf and not re-looked at. Part of it, and the reason we want to put an action plan at the back of it, is obviously data keeps changing, things keep changing. I think what COVID has taught us is, you can plan for the future, but then something happens and, we have to have a look again. And I think although we have highlighted to you some of the emerging priorities, I hope what you've seen by our presentation is there's still some deep diving to further work to be done on that data. And these are just indications of what we've seen so far, and it doesn't stop here with tonight. It doesn't stop with the strategy. We want to delve a little bit deeper and to understand why this need is being highlighted, and whether there is or isn't something that we can do to support that. We want to enrich and look at the dialogue that our working groups have been doing, and between now and November, when we start to put the draft strategy out for consultation, there will be further dialogue and there'll be further work to do. We want to make sure that our stakeholders, that we have specific areas of interest or specific challenges to be done in much more detail, and we want obviously consultation from November through to December to be really rich to inform the strategy going forward. We have an emerging delivery plan that will have actions. We will be holding partners to account. We will have timescales within it, and we will make sure that there are measurements of success within that action plan. And that will be developed as the emerging priorities and the strategy is going through its reiterations of its development between now and next April. So between October and December, the action plan will be coming to life, and we want to make sure that we've got a final strategy with a draft delivery plan, obviously available from January onwards, so that when we get towards April and our integrated care system is coming into place, that we have and we're ready with a strategy and action plan that is meaningful for Rutland as a place. So my final slide really is, Jane, if you can flip onto it, is thank you for listening. Thank you for hearing where we've come to date, and all of the considerations that we've presented to you. And I'd love you to have a discussion and ask us questions on this so that we can take this forward into the strategy development. So thank you.
Thank you very much, Emma Jane. So we've got, I've got Councillor Ainsley's coming straight in with his hand up.
Thank you, Chair. Yeah, this is a really sort of general question. First of all, thank you for the presentation. Thank you for the plan. I think in broad brush terms, it's a very welcome plan, but I do have some pretty much grave concerns, I think. And one of that is cross-border support when we look at national health systems. If we're going to improve the health outcomes for individuals, we do have to seriously look at what happens when we go outside of Rutland and we say go to Peterborough or Stamford or any other areas. I mean, I, as an IT specialist, have a particular focus on the fact that we're unable to exchange information. We still have to shuffle bits of paper around. And I think it's really important in this modern day and age that we seriously address as part of this plan how we're going to exchange information between different bodies. And I don't think that's, and I can think just very recently where we had vulnerable children who reported out of county and then unable for that information to be linked up to the information that was available within Rutland. And I worry greatly that although we talked a lot about data, we talk very little about information. This takes actually a huge skill to deduce information from the data that we're presented with. So I think I sum up what I was trying to say is that, one, I do worry hugely about cross-border support. It isn't very clever, is it, to just consider Rutland and or Leicestershire. We actually have to look the other side of the coin as well. And I wonder if that's been really thought about and addressed. And also I wonder whether we're actually looking at the IT systems that support these wonderful aims that have been articulated within this plan so far. Thank you.
Thank you, Councillor Ainsley. I don't know if anyone wants to come back on those points. Rashna, I see your hands up.
Thank you, Chair. And I share Councillor Ainsley's worry about the IT systems. We are singularly useless across the NHS and care at putting anything kind of sensible, which, if you think about the day and age we find ourselves in, you just can't get your head around it. What I will say is that we were the first sub-region in the country to link our social care data and our primary care data. So the information that my colleagues in Rutland County Council use is on a system called Liquid Logic, which links beautifully into something called System 1. Now, we had to go all the way up to Dame Fiona Caldicott, who is the National Guardian for Information Sharing, to get that agreed. So we had a big fight on our hands, but we were successful and we've done it. So what I'm trying to explain, Councillor Ainsley, is that this is not beyond the wit of man at all, and we should absolutely be including this as part and parcel of our plans as we go forward. We do have a digital development group which spans not only our system, so not the Leicestershire and Rutland region, but goes across the entirety of the East Midlands and covers now West Midlands as well. The reason for doing it that way is largely to make sure, as you say, that where people go across borders, and remember, a border at the moment is just a line on a map, it means nothing to people and to communities. So how do we actually make sure that some of that happens? So there is a national programme of which we are an exemplar site, and we will seek to put some of that in place. I cannot give you a time frame for that. We are still, as I said, an early exemplar site for putting together some of those plans, but they will absolutely be part and parcel of every place-led plan that we have in this system and our partner systems. It will be a requirement going forward. If I could just address the second issue that you talked about, which was the amount of data that we use. We've always in my team and the teams that we work across in health and care, we've got plenty of data. What we don't have from that data always is intelligence, and we don't use that intelligence to translate into wisdom to actually do what our patients and our communities and our citizens are telling us. So hence why you'll see the number of people you've got on screen here, the plethora of data analysts and information gathering that we are doing is to make sure we do the right things. So Viv, for example, from a public health background, can give us all the analysis. We've got our Health Watch colleagues who we know give us the real qualitative information that we know we need to put together in this plan. Those are the types of things that we need to bring together with what our clinicians are telling us, with what our patients are telling us, what our carers are telling us, to put forward the correct plan for this particular place.
Just very quickly, I might come back. Rashna, thank you very much for that very comprehensive answer. I hope we've got deep enough pockets, that's all I can say, having had a lot of experience in IT. And Liquid Logic, I have come across that. I've come across that in my volunteering, and it actually does work very well. So there are some success stories, but I think the likelihood is there's going to be far more horror stories. That's what I'm scared of. Thank you.
Can I just clarify, Rachna, just with regard to areas? Is Peterborough classed as East Midlands, or does it become central?
I think it becomes central, but all of my Peterborough colleagues are on all of our groups that we're working with, just to give you that reassurance. And I think it's been mentioned several times. So if I may, Chair, I'll just address the issue now of all of this cross-border working. So we do have what we've called a place-led work stream, which spans effectively the entirety of that central part of England at the moment, which we're finding immensely useful, not only for learning from other areas, but to share what we are doing, particularly in Rutland, with other areas to show how we have integrated health and care in the manner that we have. So we're finding that very useful. Now, on the flip side of that, of course, we're able to then make sure that we are taking into account some of those very practical cross-border issues across the 4 different counties that border us, not only for our Rutland patients, but also for our Leicestershire patients, because of course we cover everybody from that clinical commissioning perspective. So again, not perfect as it stands, but we've got mechanisms in place. And one final point, if I may, just on this, we have got now a provider network for out of counties. So that is our chief operating officers. And although I'm not a chief operating officer of an acute trust, I weaseled my way into the group to make sure that we can absolutely ask the questions that you are asking us today, so that to seek to give you assurance that we are working with our cross-border providers and our cross-border colleagues to make sure that, particularly, as I said, Rutland and our border constituents in Leicestershire do not see a service difference when they go across borders. So again, work in progress, but something that we are very cognizant of. And actually it's thanks to groups like this that we're able to do that and hold ourselves to account, so that you can hold us to account, if that makes sense.
Thank you very much, Rachna. Over to Councillor Powell, please.
Thank you, Chair. Actually, the first part of my question was about this collective partnership, working collaboration with other areas, and I think that's been comprehensively answered, although hopefully in the plan in more detail, one would also see the information for those surrounding areas in terms of what access Rutland residents have been having to facilities in the surrounding area, just like we've got here for which out of county people are accessing Rutland Memorial Hospital, because that will then give us the full picture. Just a couple of sort of honing in a bit, and I appreciate this is an overview and there's lots behind it. And I saw the priorities, which I thought were excellent. I had a bit of a question really, with sort of in the vision and the goals, there's a lot of talk about, well, not the goal, active communities living well. I'm thinking, what does that mean? Because actually all the priorities are about individual people's health, and I'm just wondering if that just needs to be thought about a bit more. We're saying this word community very, but what is it? And I'm just wondering if that should be more about Rutland resident accessing the health care that they need. Let's just leave that with you. My other point was on priority number 1, and it may be just the way it's written in terms of the other priorities, because reducing health inequalities across Rutland, great. The first why I'd have thought about aiming to improve healthy life expectancy in females is actually part of the focus areas. It's not a why. And because surely it's health inequalities generally, we all know that there's possibly lots of, you've identified some groups of which that female health outcomes may well be one. But also there is lots of hidden deprivation scattered around Rutland. And I think, I think maybe that why isn't the right why to put there. The female health outcomes should come in the focus areas. And maybe, I don't know if there's any particular thought about the hidden deprivation, and also why, and I'm asking why the 3 most deprived wards. I don't know if that's a standard thing, whether there are 3 that are a lot more deprived than the others, why. And just the format of that first one, most of the others we've got, what do Rutland residents say? And this one we've got the Rutland Health Watch engagement findings. This one just doesn't seem to fit in the same format. And I'd have thought the boundary issue, which we've all thought are very important, should really be that priority on number 3. It's sort of added as a bit of an extra about health inequalities on the first ones, but I would have thought that it's really equitable access to services for all Rutland residents. Sorry, that was a bit racing, but hopefully that made sense in terms of comments and questions.
Thank you. I think Viv would like to come in on that.
Thank you, Chair. Yeah, I mean, take on board your comments. Absolutely acknowledge that it probably does read in a slightly different way, and we're more than happy to look at that and see how we can improve that moving forward. I think one of the things I would just put around the female healthy life expectancy, I think the reason why we've sort of put that as a why is because generally people don't talk about Rutland in a way of having health inequalities, because generally you do well across a lot of health indicators when you compare to yourself nationally or with local partners. So I think it was just really put in the spotlight to say, actually, although we're doing really, really well, this is an area that we do need to concentrate on. But absolutely acknowledging that's not the only area, and we can certainly make sure that it is it is already in the focus area. But I think you're absolutely right. It is about saying that it is really about looking at that gradient and saying that it's not about the fact that if you compare Rutland to the city, you would always say that city has worse outcomes overall in comparison to Rutland. But we're all on that gradient, and we can still make things better in Rutland, even though we've not necessarily got the levels of deprivation that we might see in other areas of LLR, I suppose. So certainly we can look at polishing that up, and it is absolutely about finding those pockets of deprivation in Rutland and really looking around how we can do some really targeted work to support those underserved populations, however they may be defined, whether they are geographical, whether they are from a particular ethnic group, whether they are from a particular disability or from a different particular community. It is about looking at all of those inequalities in a different way.
Okay, thank you. So you agree that the why under that heading isn't actually correct and needs more work? That should be a more generic why, because we want to level up everybody.
Yeah, we can look around putting some more evidence base maybe around the marmot stuff and things like that around why health inequalities are so important and that sort of thing. So yeah, more than happy to look at that for you.
Thank you.
Thank you. Councillor Walters, did you want to come in here?
Thanks. I'm just seeking clarification from Councillor Powell, because I think she makes a very good point about the 3 most deprived wards. So if I could just ask, are you suggesting that it should be the conditions and circumstances and deprivation leading to health inequalities, regardless of where people are, that matter? I presume we're not going to set a health centre up in Uppingham, a special one, just because it's deprived, or Oakham Northwest, although actually both of those places have health centres. There are some very deprived people in villages and some very wealthy people in Oakham Northwest. So is that what you were saying, Councillor Powell? If so, I suppose
it was more a question why it had identified the 3 most deprived wards. As I say, we all, you know, it is perhaps a bit more a very mixed picture in Rutland. So I don't have a particular strong view of how it should be, but just to make sure that we're actually picking up that probably that more scattered deprivation. But I think to have an analysis of certain wards, if they are more deprived, is, you know, is good. But I was just wondering why it was 3, why it was just, yeah, what the rationale was behind that, really.
Viv, do you want to come back in?
Thank you, Chair. Yeah, and apologies for not picking that up in my previous answer. So the reason why we've picked the 3 wards is because there are 3 particular wards in Rutland that are at the lowest end of deprivation, which have particularly poorer outcomes as compared to other areas in Rutland. So it was more to say that we would look at do a bit more of a deep dive in those wards from a geographical point of view to start with. But that would only just be the start of the journey. So it is absolutely acknowledging that there are going to be smaller pockets of deprivation across Rutland as a place, and we need to identify where they are. And it is using that then to think about how we can translate some of the best practice for some of those areas further across Rutland. But please do be assured that when we're looking at health inequalities, we're not just looking at it from a geographical perspective, we're looking at it from a range of different focuses, and that is just probably just an initial starter for 10 in terms of where we should focus some additional attention and do some additional data digging, I suppose, to start with.
Thank you. Was that okay, Councillor Powell, or did you want to come back?
Yeah, that was fine. It was just and I agree it should be geographical and groups. That's fine. I was just interested in the rationale behind that particular statement. Thank you.
Thank you. Councillor Cross.
Thank you, Madam Chairman. Yeah, well, I have to be quite blunt. Rashna, you should be much higher up the ladder than you are. Thank you. It is very refreshing to hear your words, and I say that most seriously. John, now, your department and your staff have been uppermost in improving care in the county and have been a beacon to other counties. Why is it at this moment in time we seem to be seeing problems? Over.
Councillor Cross, could you be a little bit more specific? Problems, it's rather a large word.
I'm sorry, John. I'm slightly disappointed with this report because our county has prided itself on going forwards in leaps and bounds, and staff members have managed to think of ways of improving services and being a leader to one another. Now, if you've now had some discussions among staff members and found certain problems in the county, it's embarrassing, but has something gone wrong, or are we expecting too much? Furthermore, the problem is possibly not Rutland County Council. The problem is the weakest link, this is plural. We have NHS management, which is totally appalling. And we have our doctors' surgeries, which are in possibly a state of disarray. So I'm going to take the blame off you because I don't think the blame lies in the county council. So my question therefore to you is, why do we have to go through this report in minute detail when actually we are a very innovative council and department? Over.
Thank you. You may laugh. Okay, so I think there's two things. Firstly, thank you indeed for your praise and accolade. And we are one of the best, recognised one of the best adult social cares in the country. That hasn't changed, and most of that is because of the way we work with our health colleagues, the very people around the table. And we have integrated teams. Only today I've been approached by a deputy CEO of the Social Care Institute of Excellence to inquire as to how we do things here, and that's real. Things haven't changed, Councillor Cross. Those good services continue. Those good services will continue. This is about getting better, right? So, as you are aware, we now are going into integrated care systems where the government is telling us to integrate. Now, we're quite used to it in Rutland because we've been doing it for the last 3 or 4 years, and the rest of the world is indeed catching up. And I hope my health colleagues will agree with me to some extent there. But the government is telling us that we have to put together a plan as to how we're going to stop being so reliant on buildings such as hospitals, etc., and get care out into the community to make it more accessible. And to do that, we need to find out where those needs are. We also need to start promoting people's well-being, that is, people being healthy, so that they don't become so obese, so that they don't need so much time at GP surgeries. It's building efficiencies into the system. So it's more about us getting better, and I think being bolder in what we need to do and build on our successes to fulfill the new role and commands that the government has put upon us. And I think I'll leave it there.
Councillor Cross, would you like to come back, or?
Yeah, oh, definitely, I'll come back. Typical.
Can I just,
yes.
Sorry, I
yeah,
was just going to ask, I appreciate there are issues around access to primary care at the moment, but I would just like to point out that we are discussing the future place-based plan. Thank you. But carry on.
Were you talking? Were you talking to me?
Well, I'm just trying.
I tell you what, I'm as deaf as a post. Sorry. Oh dear. Yeah, this is typical. This is government at its best. Let's do another paper. Let's do an awful lot of talking, put lots of lovely words in there, and and end up getting absolutely nowhere. And what worries me, it's going to put a hamstring on poor old John and his staff from doing what they should have been doing anyway. Now, why haven't we got a representative from the doctor's surgeries here tonight? Is it anybody here representing the doctors?
To be fair, it's my understanding that the PCN sits under the neighbourhood part of the ICS, and we're currently discussing the place-based plan.
Listen, acronyms mean nothing to me. I like proper words. Now, this is typical. We have major problems in our surgeries, and we don't. And members, our constituents, are worried to death about getting treatment, seeing doctors, and this, that, and the other. And here we are talking about a paper. And I granted a lot of work went in there, and it's got to be done. However, we've got to go to the problem areas first and get them fixed, and then titivate with the rest of it. That is my view entirely. And I tell you what, there's a few behinds have got to be kicked good and hard. Where's that Dr. Fox anyway? She should have been on here. I could have given her another bloody round or two.
Well, access to primary care isn't actually on the agenda for this evening.
No.
But I will bring in Councillor Walters, and I think Rashna would like to come in as well.
Yeah, I'll be brief because I think we are going off the agenda item.
Exactly.
But I went to a parish council at Ashwell. I was summoned there the other day, and the answer I gave to them was Rutland County Council does not commission, own, manage, run, supervise, do primary care or acute care, in a nutshell. However, we do represent our residents, and we do campaign on their behalf. And as we change into an integrated care system, we have a stronger voice at the table. That doesn't answer your question, except to say, yes, Oka Medical Practice is a private business.
Thank you. I think Rashna is going to come in, but I am going to be quite strict that we do keep to the agenda item, because this agenda in itself is really, really important. However, that's not diminishing, Councillor Cross, anything you say about access to primary care and the problems we know our residents are having. Rashna, would you like to come in?
Thank you, Chair. Councillor Cross, you're obviously referring to other NHS management when you've just called the entirety of the NHS management appalling when we've just come through a pandemic relatively successfully. I will remind commission, that you will remember the last time we had to write an integrated plan that the government forced down us was the Better Care Fund. And the Better Care Fund in Rutland certainly is one of the most successful in the country. You will remember that we were summoned to the House of Commons to explain how we had quite done what we had done. And when we basically said, look, we sat down with our social care colleagues and our patients and our carers and decided what we were going to do with the Better Care Fund. Lo and behold, we did some really good stuff. And that's the stuff that you're talking about right now, Councillor Cross. So again, I will echo what John said. We know how to do integration here. We will continue to do integration in the way that we know that serves our patients best. And we will continue to do it properly and in the way that we get the best outcomes for those patients and the future generations that are coming. Just in terms of, Chair, I know you're trying to keep us very tight, but I will remind again the Commission, when I came to you last month and talked to you about primary care, I was not giving you a plan. I was giving you some very tangible actions that we are taking now to improve access to general practice. That will continue. It does not mean that we are writing a place-led plan for the future and therefore we're not doing anything at the moment. There are some here and now immediate actions that we know we are taking with those practices across every practice actually in Rutland, not just the ones that we are worried about, to ensure access to those patients, both from a primary care perspective and other. We continue to work with EMAS, our East Midlands Ambulance Service, on ambulance turnover times, because we know that has been of great concern recently. And we continue to work with our acute trust to get patients in and out, particularly for Rutland, and with our colleagues across the borders, as I've said earlier. So Councillor Cross, I'm hoping that gives you at least a sense that we are continuing to do what we know we need to do, as well as writing this plan.
Well, Rashna, you are even more refreshing having had a go at me, and I appreciate that very, very greatly. What I say is here to stimulate conversation and discussion, and I say the most outlandish things at times, and I'm not ashamed of it. Thank you very much indeed again.
We take it in that spirit, Councillor Cross.
Thank you, Councillor Cross. I shall bring in Councillor Waller.
Thank you, Chairman. I'm sure a number of us have some sympathies with what William has said, but I'd like to get back to the papers in front of us, if I may. First of all, acknowledging the huge amount of work that's gone into this. And secondly, acknowledging that we are doing it not of our own volition, but because it has come down from on high. That's not to say, and Rashna was actually, well, and John were both very eloquent about how well colleagues have worked together over in a number of years now in health and social care in this area. And I am very well aware of how difficult that can be and has been historically, having worked myself professionally in the area in a London authority, when there were times when I was banging my head almost literally against a wall because I couldn't get the health people to talk to me. So I do know what the background to this is. John's laughing, he's been there as well, I think. But I'd like to address this emerging document. And I think a lot of what I'm saying is about tone as much as anything else, but I think tone is important. To me, when I read it, it came across as the least important people in all of this were the patients and the residents. That it wasn't written with the person at the heart of it. Now, I'm not saying for 1 minute that that's the way you think, because I know it isn't. But I think the documentation needs to reflect some of that reality, because the complaints that I get as a ward councillor about health, actually more than social care, are about how they're ignored. And I'm going to tell you a story if the chairman will indulge me, and she's heard this, so I think she will. And I can tell you it because it's me, it's about me. I've got a frozen shoulder, and it started earlier this year. And I contacted my GP, and I got referred to the local physiotherapist that's employed by the GP practices in Rutland. And of course it's COVID, so it's all phone calls. And I have my phone consultation, and he sends me some exercises to do, and I do them. And eventually I go and see him because he's not getting any better. And he refers me on because he says the equipment in hospitals for the physio is far better than anything I can do at home. So I get referred on. And fairly quickly, I get a letter from Loughborough saying, you're on our waiting list. And when you get to the top of the waiting list, you will get a phone call to arrange with you when you can have a phone call to have a phone consultation. And I'm thinking bureaucracy gone mad, but never mind, if that's what it is, that's what it is. And then presumably after the phone consultation, I'll get a referral somewhere. Anyway, 6 months pass and I have not had that initial phone call, by which time, of course, my shoulder is getting worse. And my other aspects of my health, and this is the important bit, other aspects of my health are beginning to deteriorate. So I haven't stopped eating, but I have stopped exercising because it's too painful to exercise. I mean, netball, I'm talking about that sort of exercise, not the shoulder exercises, which I am doing every day. So I'm beginning to think this isn't good. And I'm, my late 60s now. So once you stop doing things like exercise at my age, you rarely pick them up again. And then you get other problems later on in life and all the things you talk about in your paper. So I think to myself, rude word, I'm not going to wait any longer. I'm going to ring them up and find out what's going on. And then I look more closely at the letter they sent me. No phone number, no email address to contact them. So the only way I can contact is by writing a letter. So I think I know I'll ring my GP because they were really helpful in the first place. Ring the GP surgery and they say, we haven't got a phone number for there either. You'll have to write. Now, to me, that isn't good enough. But actually, to you, health colleagues and social care colleagues, it's not good enough either. Because for all the reasons I said about my health could start to deteriorate far more seriously than the frozen shoulder over time if nothing's done. And then all that money that the NHS is going to have to spend on me doing this, that, and the other. And that's what I mean about thinking patient at the centre. It isn't changing the services, it's thinking about how, and access in the sense of empowering the patient to take the initiative as well. And I think that's missing in this documentation. Long anecdote, but I think judging by Rashna's face, it illustrates my point, my anecdote. So thank you for that. I also think in terms of priorities, given our profile in Rutland and the projections in terms of population, there needs to be a very clear focus on ageing and ageing well. I know it's there and it's there in bits and pieces across the piece, but I actually think as a priority, it needs of itself to be a priority area, because you start aging well while you're still in work before you even get to retirement and aging. I can remember a very wise man who is actually in this room, in this call, saying at one point, there isn't much point in moving to an old people's supported complex when you're in your 80s, because you'll be too old to actually get into it. You should go into it when you're 50, 55, 60, so you can grow into it, if you like. Thank you, John. And it was actually a very sensible observation at the time, a few years ago now. But if we are going to start getting people to think about aging when they're not aging, then that needs to be at the heart of a policy. So that's my thought on that one. I did wonder, because it wasn't clear to me, how the Rutland conversation that we had earlier this year, how the bits on health fed into this. And that was just me being curious, and Alan will probably tell me at some point. You needn't spend time tonight, Alan. But we can see where the Health Watch consultations are fitted in, but not the stuff that Rutland County Council did separately, which I think would be quite interesting. And I'm particularly interested in knowing how the hard to reach were reached or will be reached in the future, because I have been disappointed as I've gone around my ward to hear how few people were aware of all this going on, which is rather sad. And then my final comment, actually it links back to my first one in a sense, and it's about presentation. If you are going to focus on the patient, can it be in terms that the patient themselves would recognize? So for example, in slide 9 under focus area for action, you say nurturing self-sustaining, I can't even say it, self-sustaining empowered local communities, people at risk, etc. What on earth does nurturing self-sustaining empowered local communities mean? I do know what each of those words means individually. It's when you put them all together like that. So can we think of that sort of presentation? And can we also not, and it's picking up something Rosemary says, and I'm about to disagree with Rosemary, I think, which is actually quite unusual. I don't think we have to have a format and make every bit of it fit that format. So for example, when you're talking about on slide 8, potential priority 2, best start in life, totally understood the 1001 days, totally understood the 2 years. And then you've got, what do Rutland residents say? They say travelling is disruptive to education. We don't actually have very many 0 to 2-year-olds in school in Rutland, or indeed anywhere else in the UK. And so it's like you've put in a quote to make it fit. Now, I'm not saying that it is difficult for families who have children in school to get them to their appointments. I know perfectly well it is, and it was when I was a mum. Well, I am a mum, but a mum of child age, daughter of school age. But don't just put it in when we're talking about under twos. Just make it clear what's what. That's really what I'm saying. Because if it's not a clear message, you are taking away from the message. And then people are going to say, oh, this is rubbish, without actually looking below the words. And I think the intent and what you're trying to do in a national constraint is excellent. It's just I'd like to see it demonstrated much more clearly. And my final point, and it picks up something that was said in one of the sets of questions we had earlier on. I think it would actually be quite helpful in a preamble to this to show how it does fit in with UHL reconfiguration. I totally appreciate that this is far more than UHL and services that are offered by UHL. But nevertheless, I think from a communication point of view, it would be helpful. Thank you, Chairman. I will stop now.
Thank you, Councillor Warrock. I was on mute. Councillor Powell, did you want to come back on a few of those points?
I was only just going to say quickly that I wasn't talking about format for the sake of having everything the same. I was more interested in the content, and the answer to the question why wasn't, as I saw it, an answer under priority 1, and somehow the messages have got mixed up. But it was about consistency and content more than format, I think.
Thank you. Thank you. Do we have any other members of the committee that want to ask? Councillor Cross, you're coming back in. I'm going to keep you on a tight one this time, but feel free. You are on mute, I'm afraid. Now we can hear you.
So often things are better when I'm on mute. No, I just wondered during the consultation that staff have been doing on this, whether they have actually been speaking directly to the nurses and the care workers to find out their views on this paper. Thank you.
John, do you want to come in and answer that? You're also on mute. Come on, guys, we're all at it.
It's the time and the day.
It is.
The consultation is something I was particularly interested in what Councillor Wallace said about the need to get out there and talk to the people who don't normally express their view. That is something I am personally very committed to, and I think it's so important. And I think as a practitioner of the people that I've dealt with in the past who actually suffer silently and tend not to complain. So I absolutely take that on board, and please be assured that is something that we would look into. And I welcome any suggestions as to how we can do that. As for the staff, that's a really good question, actually. So I'm going to say yes, because the people on the IDG, also the people who sit in the subgroups under the IDG are staff, and they've been directly feeding into this. They will be bringing the views of other staff, but that doesn't mean to say that we can't go wider, Councillor Cross. So I think yes, but perhaps there's more to do. But that's just my personal opinion based on your question there.
Thank you.
Yep.
At this point, it might be worth as well bringing in Dr. Underwood just to discuss the report into the place-based plan, that some of this has come, the report into their consultation, which we will attach to the minutes. So I didn't know whether Dr. Underwood, whether you want to say a few words about that.
Thank you, Chair. For reaching hard to reach groups, Councillor Cross, this is something that always taxes us. We actually have regular contact or close contact working with the various groups, such as the Disabled Youth Forum, Age UK in Rutland, etc. And we try to sort of piggyback onto their events to get more engagement and get their opinions about things. One of the difficulties that we actually had when we were doing the engagement this time was the fact that we were doing it throughout the lockdown, and we were covered by a lot of the social distancing restrictions and heavily dependent for the first period, certainly, on digital communication. That said, we did try to, as the restrictions were eased, we did incorporate some more face-to-face, socially distanced face-to-face interviews and engagement. We sat in very cold gardens and such like to talk to people. So I hope that answers in part. We were aware that we hadn't got a great number of people involved in that. We had 139 people involved, which out of a population of 40,000 is not many. However, we specifically were doing qualitative work, which is a matter of really letting people talk freely, answering some very sort of loose questions so that they could give their own experiences, their own interpretations, etc., without us biasing what they said. So what people told us were their thoughts, and we just loosely guided the conversations as we went along. And then when we analysed, we were looking for the themes that were reoccurring. So we were looking at what people were saying. I mean, a lot of GP access, as you've mentioned, was one that came out, and we did not actually ask the question about GP access. That was one that naturally came out of the conversations and actually trumped transport and travel to be the most mentioned topic. So all the themes that were arising were really driven by the people we were talking to. So I hope that gives you some reassurance that what we've reported is what the people say. And I would urge people to actually look at the appendix at the back of our report, because we have literally copied and pasted the comments that we received verbatim. We've pulled the themes forward to make for quicker and easier reading, but if you read through the comments in Appendix 3, it gives a very rich picture of what people were telling us.
Thank you very much.
Can I just mention one thing that's been bothering me all evening, Chair? Would you mind?
No, of course.
I thought I enjoyed the presentation. I hadn't seen it before the papers were published. I knew it was ongoing. One thing that's really, really worrying me about the integrated care system, and has been worrying me for quite some time, is the fact that the funding is going to be allocated by the integrated care system. And although we are sort of asking people what they want, we've asked people what they want, and we're talking about all these grand things that we could do, I can't see any mention of funding. And I just don't know how much funding Rutland is going to have to be able, is it going to be sufficient to fund all these things? And if it isn't sufficient, are we going to be over-promising and under-delivering? And is there going to be a lot of disappointment there? And my other concern with the funding thing is that I worked on the ICS Task and Finish group for inequalities a few months ago, and there was a lot of talk about deprivation in Leicester inner city areas, etc. And I was really struggling to push the fact that we have pockets of deprivation and inequalities here in Rutland, and some of those are exacerbated by our poor transport. But there's a lot more people in Leicester City than there is in Rutland. And I'm really worried that, okay, there is deprivation in Leicester City. It does need addressing, but I'm really worried that it's going to be addressed at the expense of Rutland. And I'm really worried that Leicester City and Leicestershire are much, much bigger, so they can afford they can tolerate the economies of scale to provide their services, which we can't. So I'm worried that we're going to be underfunded. Perhaps Rachna can add to that.
Chair, is it okay if I come back on that?
Of course.
Thank you. Thank you, Jenna. As ever, very pertinent points. So let's address the elephant in the room about the funding with the ICS. So the ICS does have control of the entirety of the health budget for the Leicester and Rutland system. The funding allocation that we've given at the moment, both for 2021 and for we plan to in 22-23, we don't know yet. So as of today, we are in the second half of the year, and I still don't know what my NHS budget is for the second half of the year. So that's how behind government are in allocating those national budgets. That being said, our plans going forward, both in the plans that the team have presented today, as well as the plans that we have got at system level. So, you know, all the other things that we have to buy on behalf of patients and our carers, acute services, ambulance services, those types of things, those have already been modelled. And they are modelled as we always have been, as we always have done on the national formulas that we are given based on per capita population, not on deprivation. So that funding formula is a national funding formula that we follow, and that's absolutely, we have no intention of going down from that. What we do have an aspiration to is going up. So, for example, we have spent 4 decades in the system, the vast majority of that NHS budget in the acute sector. So a big portion of it, almost 2/3 of the entire NHS budget goes towards UHL. What Andy is committed to do, and what we've started to show that we can do, is take services out of UHL and put them in local areas, and the funding follows that, which we have never been able to do before because we've always had what's called a tariff-based system. So UHL does 10 units of activity, for example, and gets paid X amount of money per activity. Because of the new contract that we're in at the moment, what we're able to do is take chunks of that money out of the trust and invest it into communities. So, for example, last month when I came to talk to you, we talked about the community optometrist model, where we've got our, rather than going all the way to eye casualty, we are able to now access high street optometrists to look at those lower level eye issues, which traditionally our patients would have had to travel all the way into Leicester for. That's only happened, not because we've got new funding, but because we've taken money out of UHL and invested it into those community services. So what this ICS is enabling us to do already, before we were even formally an ICS, is move money around the system to where our patients need those services. And that, I think, is the fundamental beauty of doing it in this way, that we are no longer in a tariff-based system, and we can move the money around to follow patients. We are doing the same with community pharmacy. So again, I talked to you last month about opening up community pharmacists to make sure that we can see minor injuries. Again, we are paying for that by taking money out of the acute sector and investing it into local communities. That's not just Rutland, of course, that's across LLR, but it's Rutland specific to make sure we've got things in the various areas of Rutland that we've talked about. Just on the health inequalities question, Viv talked to us earlier about the scale of deprivation. And so we've been focused on making sure that every area has got knowing that every area has got deprivation and able to level up in a way that we haven't done before. So this is not about throwing all the money at Leicester City because they've got the highest level of deprivation, or Colville or Northwest Leicestershire or any other deprived areas. It is about looking at the scale of deprivation, where we are now in terms of our outcomes, health outcomes that we're achieving, and where we want to get to. So what incremental improvement are we talking about in every area? So not just Leicester City, not just our deprived areas, but on that scale of deprivation, moving everybody up. That is the ambition that Andy has set out as the Chief Exec of the ICS designate effectively, and David Sisling, our chair, has also made equally that same conversation. We've had the similar conversation with Mark Andrews to say that we would like to make sure that we can protect as much of the adult social care budget as possible in partnership with John's team, to make sure that the services that we know that work, so for example, the My Care service that we have across health and social care in Rutland, we want to grow that. We can't grow that unless we put funding behind it, because of course the council doesn't have that funding to do so. We need to do that as a system and enable that to happen to have that outcome improvement. And that's the kind of work that we're talking about at the moment. So a very long answer to a very short question. ICS budget is pulled, but we've got a very simple formula that we use to make sure that the money goes where it needs to. And most importantly, we are able to move money around the system, which we couldn't do before. And that's the beauty of the ICS.
Thank you, Rashna. Councillor Waters, did you want to come back?
Yeah, I imagine you might want to wrap it up soon, but I hope Rachna's answer also helps Councillor Cross to reassure him that it isn't just a piece of paper, it is a whole new way of working. But I wanted really to reply to Councillor Waller. I think your comments are well made, not for the first time, in regards to the future wetland conversation. And when this becomes the plan, I will make sure that the voices are heard, they are incorporated, and that it is patently obvious and clear that they are heard.
Thank you.
Thank you, Councillor Walters. According to my time, it's 20:52. I'm going to suggest we just take a quick 5 minutes so people can stand up, have a shake about, and reconvene just before 9 o'clock. And then I intend to wrap up this item by just discussing with the committee how we're going to move forward on this item and how we feel as a committee we'll be best placed to move forward. So if we can reconvene in 5 minutes, which would be 20:58, that would be fantastic. Thank you. Councillor Walters, is that a legacy hand, or did you want to come back in? Thank you. I think that's everyone back now, so I think we'll restart if that's okay. I've just got a couple of questions that I had written down that my fellow councillors hadn't asked, and it was just a quick query on a couple of the slides, and I was just wondering, where do the projected population growth demographics come from? That was one thing, and then the only other thing was with the service list coming out of Rutland Memorial Hospital. I noticed that there's some pre-COVID things that are missing on there that don't seem to have been put back through. So I was wondering, and services coming on from what Councillor Wallace said, things like physiotherapy don't appear on that list, but also one of the other omissions was the community paediatrics seem to have fallen off in 2019. So I was wondering, are they coming back? Would be my first clue. And so my first question was, is that a current kind of COVID service list, and are there plans to redo it as the pre-COVID as well? And then if I can put Councillor Waller on notice to maybe come in, because my words aren't working properly, but I didn't know if someone could answer those couple of questions for us.
Chair, I'll take those if that's okay. I don't know if I'll be perfectly honest with you about the physio and the peds. I presume that this is just a work in progress list, but I will double check with you and come back to you between meetings if that's okay via email, just to give you the reassurance that you seek, that we've got all services back. The last time I had checked, every service that we had pre-COVID was planned or had been planned to start back, but I'll get you some detail on those particular ones and anything else that's missing from the list. And I'm hoping that Joe can answer the population demographic question, or Advait, please.
Yeah, sorry, couldn't get myself off mute. Yes, so that was those population growths were taken from SHAPE analysis, which is a strategic planning tool, which is linked into the local plan, the Rutland local plan.
Okay. So I think I would ask Councillor Wallace and maybe John to pick that up, whether there's going to be a change on there, obviously, with regard, so it's possibly from the SHMA. Councillor Fox is going to come in, but whether there'll be any movement on that, obviously, moving forward. Councillor Fox.
Just to say that I've actually had physiotherapy at Rutland Memorial since the COVID, so it is up and running. I've been a patient there, so I have attended therapy. So it is actually working. It's just obviously been left off the list.
Okay. So could we ask for some clarity around the list? And I do know obviously the breast screening Laurie isn't mentioned either. So, and I know that may well come back. So there are some kind of emissions that looked quite glaringly out of that weren't on there. So, and it would be a shame not to highlight all the fabulous services that do come out of RMH, and actually our communities particularly really value those close to home. So an exhaustive list would be great. So moving forward with the committee members, we obviously have had the plan kind of put to us, and I suppose what my question would be to the rest of our committee is, as a committee, where do we want to go from here? Because obviously I know my fellow members, we really would value to be able to put input more into this. So I don't know whether any of my fellow members have any ideas on how we could move forward as a committee to give best voice to this. Councillor Cross.
Thank you, Madam Chairman. I'm a great one for leaving this to the professionals. They know exactly what is required. Obviously, we can add in certain elements as we think fit as it develops. And I think as it develops, if we could possibly have updates. Sorry? As the plan develops, if we could just be updated, we can then sort of reply by email and feed in that way, rather than having another meeting, you know, to go through it all again. Only a thought. Thank you.
Thank you. Apologies, Councillor Cross. I missed most of that because I froze. There is clearly a storm brewing. Councillor Waller, did you want to come in?
Yes, just a couple of things. Thank you, Chairman. The first is, I hope our colleagues have found our input tonight helpful on the whole. I think it is important for us as this document progresses that we do see it at key stages, but I'm sure John will advise us as when those key stages might be. But on the engagement with the populations, sorry, I think if there's anything that we as councillors can do in our own wards, that we would if we were asked. And that's my only other thought. But I'm sure, Chairman, you and I can explore how we might do that with John outside a formal meeting and communicate with our colleagues accordingly.
Do any of that, Councillor Ainsley?
Sorry, Councillor Ainsley, you're breaking up.
You sound like a Dalek. You are going to exterminate us, I think. I think there must be a storm. We'll just give him just a second to see whether he's going to undalek himself to us.
Is that any better?
Oh, that's much better. That's quite scary. Santa as a Dalek is not something we need.
Enough. Right, yes, moving on.
Just muted yourself in fine form.
I'm quite, goodness me, this is getting worse. Santa's a Dalek and then he's muting himself. That's dreadful, isn't it? So I think what we need, I'm happy to continue as is, as long as we receive regular updates. And I tend to agree with both the points made by John and indeed Gail that we can actually input from our wards. I don't think we need to contribute much more than what we're currently doing, actually.
Excellent. Was that, sorry, Councillor Walters?
Yeah, thank you. I think you've answered the question that I posed at the front, which was how involved you want to be. Now, I'm not suggesting that we should duplicate the work that has already been done, but clearly this would be an opportunity for you to state if you felt you wanted to engage in any way yourselves, to reassure yourselves as to the validity of the information we're using. That's not very good English either. I'm going off the boil as well. So I suppose I'm saying in terms of engagement with the public, speak now or forever hold your peace. You may wish to consider getting evidence from somewhere else or something. I don't know. It's not for me. I don't run Scrutiny. I shouldn't suggest anything really.
Thank you. Councillor Ainsley.
Yeah, thank you very much for that, Mr. Walters. That was exceptionally useful. I'm quite happy with the information I've been given. I just feel that we may be able to add the odd little nuance from our ward members, but leaving it to professionals and getting regular updates seems to me to be the appropriate way forward.
Okay, so my only other question to panel would be around a place-based plan and the ICS. Would we benefit from any further knowledge base, basically, on the kind of nuances on it all, because it is quite a complex system and everything. And if my fellow members are saying that they're fully on board with it all and fully understand it all, then I'll ignore that. But sorry, my words really aren't working now. So if everyone else understands it fully and doesn't want any further briefings, or would you like us to request a briefing, is where I'm going with that. And I'm looking to everyone. Councillor Cross, I'm not making sense, sorry.
I understand what you're saying, don't you worry. If there is something important that has to be raised, it should be brought up at our next meeting. But, you know, this is so important that it is better that staff and the others involved in it buckle down and concentrate on this job and not worry about briefing us, because we have confidence in you to do what you believe is right and proper.
Okay, Councillor Waller.
I sort of agree with William. I think we've all been informed very well, particularly the input from the various officers tonight about what this is all about. But I was a bit worried about what Rashna said in respect of not having this year's budget, let alone future years' budgets from government. That in itself is not anything unusual, as everybody knows, but it is possible that there will be changes that government decide to impose when we're part of the way through this. And I think if something major happens, like we've got to deliver twice as much for half the money, then we would like it to come back here. Yeah. But if things are going along the route that we've seen so far, then only if there's, well, only at the final stages would we want to see it and take up officers' valuable time, especially in the evenings. That would be my view, Chairman.
Thank you, Councillor Waller. Rashna, can I just confirm that so the budget being held at system level, would I assume correctly that that would also go to joint health scrutiny as well, and which Councillor Waller and I do obviously sit on, and there would be lots of discussion around budgets around the system level at joint health scrutiny?
So the normal thing that happens, as you as colleagues may know, is that it will go through, we normally take things through to Health and Wellbeing Board and Cabinet and those types of places. I think we had a meeting just this morning actually with our colleagues from all three local authorities about where the best place is to have these discussions. My gut feeling is as we move into the ICS that we will have multiple discussions in multiple groups. Final sign-off will sit with the NHS board because it's the NHS budget, but the entirety of how that's split out will absolutely be a partnership decision on that board, and we have representatives from each of those places on those boards. For Rutland, of course, it will continue to be Mark Andrews, and we'll work closely with colleagues in that way. In short, Councillor Harvey, I think we're still working up how that's going to work in its entirety, but as you're aware, we bring things regularly to joint scrutiny in that vein, yes.
Okay, thank you. So I've got, if I can just clarify with, as we pull this to an end, the recommendations we're putting forward is that we continue to watch on the plan as it's being developed, and that we would bring it back further when we have a more, 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 a more in-depth plan to look at. Is that right? Is that what colleagues would be happy with? I'm seeing lots of nods. And also just one thing that we've got, a one to do thing from Rashna. We were going to look at the service list for RMH. Jane, did we have any other actions that have come out of this agenda piece that you're aware of? No.
Not that I'm aware of, Chair.
Thank you. We're going to move on to the next part, which is the performance management. Just as to clarify to members, I'm going to ask Councillor Waller to take over chairing. I live with ME and it's particularly bad at the moment, which is why I've suddenly lost words. I'm really, really tired. It's been a really long day. And so my brain and my mouth are no longer working in harmony. So I'm really struggling. So rather than just trying to kind of through it all, I'm going to ask Councillor Waller just to take over chairing of the meeting, and I can sit back just for 5 or 10 minutes. Thank you, Councillor Waller.
That's no problem at all, Chairman. And thank you, everybody, for your understanding in this swapping over of roles. I think we've covered everything that we needed to cover on item 8. I would like to finally thank the officers from across the board for coming and talking to us this evening, and being very patient with some of our lines of questioning as well. Moving on then to item 9, performance management update. I believe, John, that is you.
Indeed, Chair. This is a brief verbal update, if you'll permit me, based on the previous committee meeting, whereas you'll recall we got about 30 seconds in discussing some actual ASC KPIs, and myself and most of you started to scratch your head and say, why are we talking about these? And when we then started to have a conversation, we decided that they were 5 or 6 years old. There was no basis. The world is a very different place in ASC. We've now got integrated teams. We work closely with LPT. We work with our CCG colleagues. We have a joint PCN team, nothing of which we capture data for, which was pretty pointless.
Could I raise a quick point of order, Councillor Chair, if I may? And that is that we have, sorry,
Yes, you may, Councillor Ainsley.
Thank you very much indeed. Yeah, it's just that we have a lot of people here who probably have had a very long day, and I'm just wondering whether we need everybody here at this moment and whether we can actually release some into the wild.
That's a very, very good point, Councillor Ainsley. If you don't need or want to remain with us, we will say good night and thank you, and just disappear, please.
Thank you.
Thank you.
Rosemary, is that a new hand?
– Yes.
Please speak.
Can I just a quick, and I appreciate, I mean, I am getting my head around all these acronyms, but I would be really grateful if we could, I know people are used to them, but it is, especially it can be a bit confusing at this time of night to be galloping through acronyms. So I for one would actually quite appreciate if we could have the whole words for most of it, if you don't mind, John. Thank you.
No, thank you for correcting me on that, because I'm the first one that jumps in and says that to other people. It's because I'm trying to gallop through it.
Yeah, I appreciate that, and we probably.
No, that's absolutely right. But can you still hear me? I heard something go strange.
We can hear you, but you're a little quiet, John.
Right, okay. I think my batteries are going flat in this. I'll speak up a bit. Okay, so to cut a long story short then, we had a meeting, my senior team, myself, Councillor Harvey, Councillor Waller, and the business intelligence from the council. And what we've decided is that we would give you all of our KPIs and what's happening is a pro forma is being put together to enable that to happen with all the new information. But it doesn't just end there. We're not just going to dump it all on you. It's then for you to have a look at what you want to ask us about, which would seem a much better way of doing things. Because I don't want to be giving you things to scrutinize me. I want you to be having a look at what I do and then tell me that perhaps we need to be doing something a little bit better, or being inquisitive and asking why some things are different from others. And we've also agreed that where we can, we will bring budgetary information to the KPIs that you choose, because that of course then gives us and gives you, more importantly, a fuller story. And I use that word story on purpose. It gives you the story behind the KPI and the opportunity then to look further. And I'll leave it there, Chair, if that's okay.
That's absolutely fine. I think one of the things we were all struggling with as a panel was what we wanted to see, and having seen it, what we wanted to ask. So the first step of seeing what is available, I think, is important. But the last thing we want to do is to spend scrutiny meeting after scrutiny meeting going through pages and pages of data if it's not actually of interest to us in terms of our global concerns. So thank you, John. It's a step forward. I think it might take a little while for us to refine down to what we want, but we'll see where we go. Okay, moving on to item 10. Item 10 is a standing item on the agenda. You have the scrutiny work plan for the year. This is the opportunity for you to ask for additional things, to comment on it, to say, oh, don't think that's relevant anymore, or any such comments. Paul.
Thank you very much indeed, Chair. I really do feel that we need to put the focus back onto primary care and the issues that have been experienced in the community. I've got quite a bucket load of emails, and I know lots of others have shared their concerns about access to primary care. And I was interested to note during today's briefing that actually it wasn't just confined to Oakham medical practices, but actually right across the piece. So I would love to have a breakdown of the current situation regarding primary care and what the improvement plans are, because I don't believe I've seen them. It could be my negligence, of course, but I have no idea what those improvement plans are. So I think that's something maybe useful. Over to anybody else?
I'd like some clarity on that, please, Paul. Are you talking about the practices within Rutland, or the practices which serve Rutland residents and therefore would include Stamford particularly?
I think, yeah, sorry, I wasn't on mute, just checking. I think that actually, good point, that actually it probably is actually the practices that are accessed by the community as opposed to those that are geographically limited within Rutland. So I think that I just know that my inbox is, and quite a few people have approached me, and that's unusual, to actually talk about the access to primary care, and it's a real issue. So I think I'd like to see the improvement plans, etc.
Thank you for that. What do others feel about that suggestion? Sam?
I was going to say we have put the we've still got the catch up from the last meeting from Bashna to bring the improvement plan forward from OMP, but I agree things should be improving by now, and when we're going to be moving into winter with winter pressures, we know the pressures on our EDs at the moment are they're through the roof, and that will push more people back into primary care, and so I think we should probably bring it forward to November, if unless we see a massive turnaround in the next few weeks. That would be my view.
Sam. Thank you. William?
Totally agree, Madam Chair, and both speakers there. But it was interesting because when I spoke to the nurse this morning, I praised them for all the hard work they're doing, and I said, how are the doctors getting on? She said they're working very, very hard, but where are they working? That's the question. I think we do need an explanation from the various practices of what the doctors are actually doing, so that we can pass that on to their patients, because the patients just meet a brick wall. Thank you.
Thank you. I'll bring Janet in now.
Thank you, Chair. Really, it's just to update you all. I was fortunate enough to be at a meeting with the CCG Experience and Engagement team a couple of weeks ago. They've just done a massive survey across the whole of Leicester, Leicestershire and Rutland on GP access alone, and it's given them a lot of very insightful information, which they are going to, they tell us they're going to act upon. They can't make it public at the moment because they have to take it before the CCG governing body to get approval before actually pushing it into the public domain. So that's that one. Second handle, if you like, is the fact that we've been doing some work on GP access as well, and have been asking people to tell us about their experiences of accessing GP services, etc. And we've got a report that we've just got to get approval on before we publish that. And this is, whereas the CCG one is quantitative, the work we've been doing is qualitative. So they both go in very, they dovetail quite well, actually. Ours is just on Rutland, not Leicester, Leicestershire and Rutland, but that will be coming out shortly as well, and that will give you some indication of the depth of feelings that are about.
Thank you, Janet. I think we probably are picking it up as ward councillors, actually,
Yeah.
those of us who are. Sam, you want to come back in, and then Paul?
Yeah, I would just like to slightly defend our GPs, whilst it is incredibly difficult to get to get in for a lot of our community. I will say personally, because obviously my mother unfortunately was diagnosed terminal and subsequently passed away. I do know firsthand that actually our GPs are out there and are giving a second to none service when you're actually in front of them. And actually I had our GPs coming out after death, and they were fully supportive. And actually on the day my mother died, our GP, one of our GPs, had been at a meeting with the CCG at 7 o'clock in the morning over the weekend. After my mother had passed away, he had been with 4 other families who had lost family members who had passed at home, and he was again at my house at 10 o'clock in the evening to declare and to offer a really lovely service. So I think whilst it is incredibly stretched and difficult, I think we do need to acknowledge that our GPs themselves are putting in 17, 18-hour days, maybe even longer, and actually that does need to be acknowledged.
Thank you. Paul?
Thank you very much. Yeah, I think part of my problem is I seem to be operating in a vacuum as to what actually is happening. I have the greatest respect for our professionals within the National Health Service, and for our GPs in particular, and also Janet, for your opinions and work that you're doing. But I do feel that we are operating in a bit of a vacuum, and I have nothing to say to residents really. I know they say to me, I can't get an appointment, and I say, well, we don't commission it, we don't, etc. But we are the voice, I would remind you, of the people, and we are the voice of the community. And I think it would be exceptionally useful to raise this. And I'd really like to get my hands on an improvement plan, what the real issues are, and see what can be done to address the real issues that are stopping residents getting the first level of care that they need at their GP practices. Thank you.
Yes, I have written down what you suggested, Paul. I'm not saying I disagree with you or that I agree with you. I have noted it. You've had support from William and some support from Sam. In fact, I would support this for the very reasons, Paul, that you've given, that we are meant to be the voice of our residents, and we are not as clear as we should be about what is going on. Rosemary.
Yeah, so just to support that, because that is the issue of the moment. I don't think there's any question about the services that are given by the GPs and the quality of it. The problem is in the management of access and the management systems. And the last thing I went to, which I think was a Health Watch thing, I was actually disappointed that we got all the reasons why things weren't happening. Now, what we need to know is what the plan is to improve them. And I don't really want to hear any more about why things can't be done or what the problems are. I think that's what our residents, that isn't useful to have information about why it's not happening. It helps to have a bit of understanding and empathy with that. But actually, what we need is to know what the actual action points are that will make it better, because it's appalling.
Yes,
and I don't want a session where we just hear again what the problems are.
Can we sorry, Rosemary, I'll let you come back in a moment if you wish, but Jane's put her hand up and I know what she's going to say. She's going to say we've got to ask for extra, I've got to ask for extra time, and that needs to be done by a recorded vote. It's because it's almost 9:30. Jane, can I hand over to you, please?
Yes, if you're in agreement to extend the meeting, please would you raise your hand? Thank you very much.
Thank you, that's unanimous. Right, Rosemary, sorry to shut you down as I did.
No, I mean, I think I'd finished. I think that's my point. We don't want to spend time listening to all the problems again. I would support Paul say, actually, we need to know what the plan is and when things are going to improve.
Yes, thank you. Janet, is that a legacy hand? Yes, it looks like it. Right, what I've got then, and tentatively for the meeting in November, that we want to have access to primary care for Rutland residents, which is the improvement plans for the surgeries where there are improvement plans. We want to be able to see those in advance. And we want some input on how the surgeries are operating in the current climate, because once upon a time you'd ring your surgery and you get an appointment with your GP. Well, now you may well get an appointment with your GP, but it'll be a phone appointment. They're not automatically seeing people. And I think we need to understand if that's permanent, if that's just transition, if it's COVID related, and all those sorts of things. And we need a discussion around that. That's the sense I get, not revisiting the, oh, but you can't get through if you try ringing, because we've been there and we've, I think, exhausted that ad nauseum, because we all know what the situation is. Sam, you want to come back in?
Yeah, I was just going to say it might also be worth getting some data around Latham House. I don't know whether Health Watch or our colleague, Councillor Powell, or our other colleagues where a lot of our residents towards that area do, and I've heard anecdotally that there's also maybe some issues there. So it might would be worth seeking some advice on Latham House.
Okay, thank you. Janet?
Yeah, I would concur with Councillor Harvey on that. I've heard problems because I live just 4 miles from Melton. A lot of the residents of my village are registered with Latham House, and I've been picking up these adverse comments as well. They do seem to be having the same sort of problems. I've also heard sort of anecdotally that a lot of patients are leaving Lakeside Healthcare in Stamford and registering with Empingham practice, and I think I'm not picking up any dissatisfaction there. I'm not wanting to cast any aspersions, but I am concerned that if this trend carries on, they'll be putting too much pressure on the other practices they're moving to.
That is certainly potentially the case. And as far as Empingham is concerned, whilst they have planning permission for some temporary additional facilities. The actual site is very limited, and it's something that the parish of Empingham have been concerned about for a little while. So it's quite a complex problem there.
Yes, I do know that politically, and I mean national politics or local, I don't know, the Conservative Party, our MP is pushing for a second surgery in Melton Mowbray, but I don't know how she's getting on with that campaign and how that will alleviate the pressures from some of the Rutland.
I think we need to potentially have some representation from the NHS, I use the term loosely, the commissioners, just to reflect back their thinking on these issues as well.
They have some ideas, I mean, I can't divulge them because I've got them written down somewhere, but not in front of me, and I can't recall at this time of the day exactly what they are, but they have some ideas for actually improving things. One of the big comments that we picked up as we were doing our recent project was that, and the place-based care one, was that people were ringing up, they were having great difficulty in getting through, and when they got through, they spoke to a receptionist, and the receptionist determined who they would be referred to, whether it be a GP or a nurse, etc. And people are resentful of being what they saw as triage by a receptionist, but it's been explained to us, and I'm just giving you the information I've been given. I'm not saying whether it's good or bad or whatever, but these people who we think of as receptionists are trained care navigators, and they are actually trying to send people to the most appropriate healthcare professional. So if you ring up with, say, a backache, they'll probably refer you to a physiotherapist. If you ring up with a problem with your medication, they'd send you to a pharmacist. And all of this is to try to reduce the pressure on the GPs. But the public don't seem to understand that. And we've actually said several times that communication is key here. The public need to be informed about what these receptionists stroke care navigators are, what they do, what their role is, that sort of thing. And that would probably remove some of the frustration. I'm not saying it will remove all the frustration. If you're trying for an hour to get through and you're getting repeatedly engaged, and then when you get through and you're told there's no appointments, then to ring back tomorrow, that's not satisfactory. The other point that actually, this came from my husband, who is not at all interested in healthcare matters, but he said to me, you can ring up, you can eventually get through and you get an appointment, but you're damn well not going to spend another 4 or 5 days trying to get through again to cancel the appointment if you don't need it. And you can't cancel. You can't easily cancel appointments, so people aren't turning up.
That is, I think, relevant. I mean, missed appointments has always been a problem in the NHS more generally. And I think it was obvious to me the last time I rang that the receptionist was more than just a receptionist, but she did what any good person in that situation would do, was, and are you happy with that? When she was suggesting something other than a GP, which gave me the opportunity to come back and say, no, I'm not. In fact, I was, but then she would have been able to explain why. And I think a lot of the communication isn't just us telling residents, it's that the people who are answering the phone need to think about the patient. It's what I said much earlier on about the patient needs to be at the centre of everything.
I do recall, with you saying that, I do recall one of the things that the CCG were suggesting they should do is do better training for the care navigators, stroke receptionists.
I think I'd like to pull this to a close. I will allow Sam to come back in because it is her committee after all. But these are the sorts of discussions that we will have if we have this on the agenda next time. Sam, you want to come back in?
Yeah, just a couple of points. I was just going to make note, and hopefully you'd be able to give the day, because for the life of me, my brain can't bring it out. But the patient participation group at Empingham surgery is being reformed, and I think, is it Saturday that they're having their first meeting? But obviously we would, Janet's shaking.
It's the 13th.
Thank you. So we would recommend that all patients be part of that group, because the more voice that they have, the better. And then finally, just on with regard to the work plan, in our February meeting, and I'd made a note earlier, I don't know whether colleagues were thinking that might be a good time for us to bring the final draft plan of the place-based plan, whether we could fit that. I don't know whether a word we can speak to John with timings after that one with Councillor Walters, and whether we'd be able to, as a scrutiny, it might well sit quite well in that February meeting for us to look at the draft plan.
I mean, we have got the adult and health scrutiny work plan in front of us. I have noted everything about primary care for November. I think we will need to have a conversation with John, the chairman, and myself as vice chair, about the timing of all the items that we've got on this plan, not with a view to losing any of them, but simply to have them at the right time. So I think that's a given. There is something else that we were going to raise, and that is discharge from hospitals to care homes. I'm not sure that's a topic for this committee, or whether it's simply that we would like some information about it, but I'll flag it now. If it's anything anyone wants to talk about, say. If not, I'll follow up with a more sensible email to John tomorrow with what it is I'm actually getting at here. But I had got a note for that.
Yeah, no, I was just going to butt in and say, would that fit in with our we've got the support given by adult social care, home carers and care homes post-COVID up on the November, and there was just whether we could slot in around discharges to care homes within that, John. But Councillor Waller and I are happy to discuss that outside, if that's helpful.
Thank you. Rosemary.
I was only just going to say, following on from John's update earlier on about the performance data, we should make sure that that's in at the appropriate times if we're looking at the KPIs and deciding what we're going to pick up from there and any particular areas to look into a bit further.
Thank you very much, Rosemary. You're quite right, and I've made a note. John, you want to come back in?
Yeah, Chair. Also at that meeting, I didn't mention, we spoke about adult social care having its own risk matrix. I've asked my senior team to have a look at that. We did have one, it was suspended because of COVID, but that might be a wise thing. I'd quite like to have that brought forward at some point, not just yet, if you'll do me a bit of a favour. But I think with all these changes in social care post-COVID, it would be good, I think, if Scrutiny did have a site of our specific risks as we saw them as a service.
Thank you. And I think from my days of chairing the Audit and Risk Committee, that they would be very happy for this committee to look in detail at your risk matrix. Not they would be very happy for us to. It was something they were encouraging. The Audit and Risk Committee were encouraging scrutiny panels to look at risk in their scrutiny areas. Sam, is that a legacy, or are you coming back?
No, I was going to come back just on Councillor Powell's point, and please, John and Gail, please help me out because the brain really isn't working. Did we discuss in with the KPIs and things that we would pick out one aspect for qualitative work, and actually where we see public health and CCG performance data on the agenda, so I'm looking at November and April, that would be that we would have kind of like a standing item. Please, one of you help me out because my brain is really struggling with it to explain it better than I am currently doing.
John?
If I understood that, are you saying that because at the last committee you asked for the CCG data to be returned, to come back? Are you saying that you'd like a standing order perhaps once every 6 months to have it all together? So the CCG, we've just actually grown public health in Rutland. Viv, who you saw earlier, was our very own consultant for the first time. And also ASC, because I think that would be quite a good idea. It would also give you opportunity to triangulate the information, which would help going into an ICS actually.
I think that's right, but I don't think that covered the performance data from your department, John, that you're putting together for us now. And that's the bit of the jigsaw that we need to fit in somewhere along the line.
Can we have a, it wasn't what I was thinking, so I'm really sorry, my brain has left the building. So can we follow that up afterwards when my brain re-engages so that I can let everyone know exactly where? I know that we discussed something and which was really would be really helpful, but it's gone. Apologies.
No, don't apologise at all. You go and get some rest. That's what you need, Sam. Janet, unless it's absolutely crucial, I would rather move on, please.
It is absolutely crucial. The PPG meeting at Tempingham is the 15th, not the 13th.
Oh, that is crucial. That's Wednesday.
Yes.
Yeah. Okay, thank you. If there's nothing else then on the forward plan, annual work plan, it's the forward plan of the council and the annual work plan of this committee. If there isn't anything else, I will move on to item 11, and we haven't been informed of any other urgent business. The next meeting is Thursday, the 25th of November at 7 p.m. We have talked about the agenda items for that tonight, and I would like to thank you all for your attendance and diligence, and I will close the meeting at 9:45. Thank you very much.
Thank you.
Thank you all. Good night.
Thank you.
Good night.
Thank you.
Thank you, Gail, for stepping in. Apologies.
No probs.
Right, good
No
night.
probs.
Good night, everyone.